I think I will give kind of the greater overview of this and what we're doing and what we're trying to do. And then Ashish Gupta, who works with me and actually is kind of running the registry, will give the nitty gritty about how the registry is set up and how it functions and whatnot, because he's much better suited to doing that than I am. But just to start, I think we've been interested in adrenal leukodystrophy for a long time, and we've done probably several hundred transplants and in boys who've been affected with cerebral disease. So we've seen a lot of boys with ALD, but the ability to have newborn screening and be able to see them before the onset of cerebral disease is really something that we haven't been able to do before. So I think it's very clear that newborn screening is going to save lives. Um, it's also very clear to me that we don't know anywhere near as much about the disease as we would like to, and part of that is if the boys are picked up by newborn screening, um, who's going to get cerebral disease and whether we can predict who's going to get cerebral disease, and if there are factors that might influence whether they're going to get cerebral disease. Those things we don't know. And now that we have the opportunity to potentially follow the boys for the long term, as opposed to just see them when they have changes on their MRI, it gives us an opportunity to do some research that we wouldn't otherwise have had the opportunity to do. So several years ago, as part of that discussion, we decided that we were going to look at setting up a registry. And globally, there's a couple different ways to do registry. One would be to do it with the providers and have the providers report data. Um, and the other would be to work with the families primarily and have the families interact with us and help get the data to us. And so we decided actually to go with the latter approach. Um, Partially because there are so many different providers seeing the patients that getting buy-in from everybody would be really difficult to do. So we'd miss a lot of patients, and the reporting would probably be relatively spotty. Plus, the best way to get the data is to, um, potentially pay people to do it, so they have some, uh, you know, we can compensate them for their time essentially. And that obviously would get quite expensive as well. So anyway, the decision was made to go with a patient-based registry, recognizing that then people would have to opt in to do it, and weren't going to get everybody. But that's what we decided to do. And again, Ashish will kind of give you the specifics about how this is working. But um, what we wanted to do is be able to have people sign up, and then on an ongoing basis every 6 months get more information from them, how things have changed, whether there's any phenotypes that have developed, what their testing looks like. We have the opportunity to actually get their MRIs here, and we can store them so we can look at those things as well. So that's what we initially had developed the registry to do. But it became pretty clear, and especially talking to people at Lisa's meeting last year, that others would like this type of data as well. And especially some of the groups that are doing the newborn screening, the states wanted to have some sort of long-term follow-up in regards to their patients as well, so they know how they were doing. And the mechanisms for each state to do that is difficult. So uh, we kind of went back to our group and said, is there some way we could potentially do this? And I mean, long story short, essentially, the consent is electronic, and we added into the consent a couple of questions, one of which is it okay if we provide data back to your testing center? And so now that modification is through the IRB, we're going to have the opportunity to do that. We've been talking to the APHL group, who've been remarkably helpful in this as well. And they're going to help us with this, help us fund this additional piece of being able to work with the centers and potentially get the data back to them. So with that, I think I will turn this over to Ashish, because he's got the slides and can then walk through how the registry is set up and how this works.
Hi, I'm Ashish. I'm one of the transplant physicians working with Dr. Archard, and I will run through the basic elements of this registry. Is it okay if I share my screen? So this is the ALD National Registry, which is based out of University of Minnesota, but the goal is really to have this available to the providers and the families nationally. Okay. So just an overview, like it's a family-based registry, and there's a biobank attached to the registry as well, as Dr. Archard mentioned. We have tried to make it simple and easy for the families who are interested in enrolling. It's a single click actually to begin the enrollment, and I'll actually walk you through the process, how it works. The entire study enrollment and participation can be done remotely. So we did not want people to travel all the way to Minnesota, and especially in this winter, there is nice snow for falling outside right now, um, to really like participate in this registry. So it took a lot of effort to get it all online and do it in a remote participation way. And it has been really helpful, especially in this pandemic where people cannot travel. This registry has like not stopped the enrollment, and we are still moving on with the participation on this. This registry is open to all children as well as adults with ALD. And I specifically mention here females with ALD because that is one of the groups where there is very limited data and research right now. And as many of you know very well, that it is not that the females with ALD do not have symptoms. There are issues that need to be addressed. So that is one cohort that we have included in this registry as well. So the steps that are there in this registry include the initial survey and expression of interest form, which is that single click, which is what that single click leads you to. Once you fill out that form, and again, I'll walk you through like how that form looks like and all that in subsequent slides. Once you fill out that form, we reach out to you depending on what method of communication you mentioned in that form. And we discuss about the registry, and if you guys, if anyone has any questions about any component of the registry. Once we are in agreement, we will send you a consent, which is an e-consent. It is an Adobe-based consent, which is date and time stamped. And I will again show you how it looks like. It can all be done online. Again, if there are any questions, you can always reach out to us about the consent piece. And once that is signed, it has a HIPAA attached to it. It has a release of medical information attached to it. All of them are signed online. Once that is completed, we get notified. And the next step, and then we move on with the next steps. The very next step is actually an online survey, which has multiple components to it, and I will describe that in the next few slides. Once that online survey is completed, we actually, our team like simultaneously starts working on procuring the biospecimens and getting the medical record from different providers. Medical records are used for data abstraction on this study. And again, we'll talk about the elements that are there on the registry for that. And after that, we actually send a follow-up survey every 6 months, and we procure more biospecimens like every 6 months. So the survey and the biospecimen piece is every 6 months. So this is kind of like a prospective longitudinal registry, where the goal is to collect all this information and have an online follow-up as well as a biorepository for a longer term use. So this is the initial expression of interest form. And I just also want to introduce you to the website that we have developed for this registry. This is ALDNR for ALD National Registry.umn.edu. If you click on that, it will take you to this web page. And if you scroll down to the bottom of the web page, it will give you a link to open this expression of interest form. So so this form is pretty like simple. These are just these 6 questions in there. Um, like if you would you like to participate, first name, last name, and your email address, phone number, and what is your preferred mode of communication, and if there are any comments. So once you have filled out this form, the next step is actually we'll reach out to you, discuss about the registry, and then we will work on the consent piece. So the consent is again online Adobe-based e-consent. This is kind of like what the initial form looks like. It This has been one of the biggest challenges with this registry, or like putting up a registry like this, was actually that like the consent has to be FDA Part 11 compliant. It doesn't need to be, but if you are Part 11 compliant, then there is a lot of research that can come out of this, which are kind of like approved by FDA norms. And as I mentioned, the consent is date and time stamped. So when you're signing the consent, this is what it looks like. There is an electronic signature. You can enter the name of the child. And again, if it is an adult, you can enter your name. And it shows up like this. It is electronically signed by the person, what date and what time. And then there is a date, and there is kind of like a whole e-consent stamp of the person signing this consent. And these are the optional elements that Dr. Orchard was mentioning. So on this study, we have let the family decide what optional elements they want to participate in. One of them is about the genetic information, because on this study, among one of the biospecimens, we are collecting the DNA like via the buccal swab. The other information is sharing this periodic health updates with the state newborn screen program. And the third thing is to if they're okay with sharing their contact information with the ALD advocacy groups. So all these are optional elements, and like I will show you the data that like all the families have very positively participated in these optional elements. So then comes the intake survey. Once the consent is done, it is again a REDCap-based survey, and it collects basic demographic data, provider information, the disease-related data, some family information, the symptom and treatment history, as well as the barriers to care, which actually is an important component here as well. So these are the different variables of the online survey. Again, under the demographics, we look for name, age, date of birth, gender, race, ethnicity are going into the next modification of the survey. Phone, email, address, the provider information, all the different providers that they see, the disease history, like the date of diagnosis, how was ALD diagnosed? And again, like these questions have quite a few branching logics there. So if say they like when this question comes, there are different options, like was it the newborn screen, was it the family history, was it adrenal insufficiency? So if someone clicks on newborn screen, then other questions pop up, like what state was that, and what date was that, and all the other stuff. If they click on the family history, there are other questions that pop up. And then we ask about if there was a biochemical testing like the VLCFAs or the genetic testing that was done, was there any imaging done, and if there is a known family history. Again, some of the questions you will find it in a couple of places which might like look similar, but that is actually one of the survey tools which are sometimes important to make sure that family has the option of putting data in different places. And then the more variables on the survey include the current symptoms. Again, these are just some of them that I've put in there. Is there any treatment history, Lorenzo's oil, or other treatment options? Now, one thing I would mention that on this study, we have actually excluded patients who have undergone transplant or gene therapy, because the goal was not to really get more samples or more information from those patients. Like the ones who have undergone those two treatments or undergoing those two treatments, they are like pretty well pretty closely followed by the treating team, and the gene therapy study is like a 15 years follow-up. So we excluded those two groups, at least right now. Those are excluded from this registry. And then the barriers for this for the care, which again we feel is a very important component here. Was it lack of information? Was it lack of provider knowledge, the familial nature of the disease, or different phenotypes of the disease? So all these questions are there in the initial intake survey. And then, as I mentioned, we simultaneously work on procuring the biospecimens and the medical record data. So from the medical record data, what we are looking for is our other comorbidities, medications, any other treatments that someone is on. We also extract the laboratory data, which includes the VLCFAs and the genetic testing data. We also extract the renal function test results and if there are any other relevant test results that we feel it is important for the registry. We also get the MRIs. Right now, we are only requesting the disk, but we are also in process of developing an imaging server for this, for the registry specifically. And then in 6 months, we do a follow-up online survey, and that is actually pretty short. It is basically looking into any change in demographics. People move all the time, so we want to make sure that we are following them wherever they are. Any change in symptoms, any new family members diagnosed, and any new treatments that have been tried since the last survey was completed. Regarding the biorepository, we get the buccal swab once at the time of enrollment on this registry, and the blood, urine, and stool are done every 6 months. Now, for our patients who have been followed up in our ALD clinic here in Minnesota, definitely this is something that they do during their clinic visits. For the remote patients, we have a whole shipping kit actually that we ship out to the families, and we try to coordinate this with, say, if a child is due for the blood draw for renal function testing. So we coordinate with the family and ship out the kit a week or a few days before the blood draw, so that they can take it to the provider during their day of blood draw. Urine and stool kits, they are kind of like a self-collection kit, and these are provided with all the instructions. And the shipping kit has like the whole package is kind of like has a cold pack and everything, so samples are pretty well preserved. I would also mention that for adults and adults with ALD, including the women, we are modifying this a little bit to every year, realizing that adults don't get blood draws that frequently as compared to children with ALD. So we will space it out a little bit more over there. So just looking at the current data, we have about 154 people. And again, thanks to all the families who filled out this expression of interest form. And after the modified consent, which included the optional data elements, there were 82 participants who have signed up for this. Among that, there are 35 children and 47 adults who consented. And I am very proudly mentioned this, that there are actually more women with ALD who have consented on this study, and we are really excited about it. I also want to mention that everyone who opted to share data with a newborn, everyone who consented actually opted to share data with the newborn screen groups, and majority have said yes for sharing data with the advocacy groups as well. Just to give you a quick example of how and what we expect from this study, so this is just a quick analysis. Again, we have not looked into the whole data, but I was just playing with the data yesterday to get an idea of what families have responded. And one of the very important components of this registry is to understand the barriers to access to care. And these were some of the responses actually to that. And as you can see, limited treatment options and lack of disease knowledge among the local providers has been a big challenge for most of the families, as well as the lack of information about ALD. So again, this is just to give a snippet of what we are hoping to get more idea on, so that we can develop future interventions based on this. And also like to acknowledge all the patient families and providers who have helped us build this registry and who have enrolled on this study. The advocacy groups, Be a Hero, Become a Donor Foundation, APHL, thank you so much for the grant and the support with this registry. And of course, University of Minnesota, where this registry is based. I'm happy to answer any questions related to this.
Thank you very much. We do have one question in the chat from Janice Sherwood, asking if we should fill this out for boys who are now deceased but had ALD.
I don't know if you want to address that, Ashish, or not. I don't know if that's actually come up. I mean, the goal of the study was to be able to do longitudinal, to get longitudinal data and whatnot. So, you know, if the family has a lot of data over an extended period of time, that may be useful. I don't know if anybody has signed up who have already, the boy's already been lost to transplant or some other other event, but I don't know. Can you address that, Ashish?
Sure. We did not have anyone who has signed up for someone who has already been deceased, but that is a very, very important question, and I think that will be important data as well. We'll have to look into how we can capture this, because as per our, like, what we put in through the IRB, we are like only capturing data for people who are living right now. But I completely agree, that is an important piece of information.
I'm just kind of looking at the questions here too. So one is, would you reconsent people when they reach age of majority? And so, the answer to that is going to have to be yes. So um, there's a couple populations right now. The adults that either have AMN or women that are carriers that are signing for themselves. And then most of the other patients, of course, are going to be boys that either were picked up by newborn screening. And we have a number too, Ashish, and I don't know what the actual numbers are, but uh, through boys picked up by newborn screening, or girls even, there are, brothers and cousins and, others as secondary diagnoses that are made. And so we got a number of patients on the registry kind of on that basis too. But again, those are probably going to be mostly younger patients for now. But over time, as some of these patients get to the adulthood, they're going to have to reconsent on the study.
Yeah, we have a mechanism in place that when we see that they are approaching 18, we let them know that there will be a reconsent. There will be they have to reconsent, and there will be another consent coming in. And we have different consents for different age groups. So they will be signing the adult consent form, and our group tracks it very closely, who is getting into that reach. And I think that is the advantage of this study, to be honest. And doing the e-consents, the whole process becomes way more streamlined. You can actually put things in place where, like, the reminders will be flashed, and like the consenting is such, like, so much better. Like it is like, trust me, it is not going through that whole ordeal of like the paper consents and stuff. You, like, everything is very secure, and like I feel that it has been much more easier to do the e-consent on this study than like other studies that we do.
Okay, the next question is, have you met unusual onsets of the disease, both symptomatic and asymptomatic, during this process?
It's a really good question, and I'll be honest. Like, we have not sat down and analyzed the data, and it is sometimes I do this. I do look at the individual surveys and see if there is anything unusual, but it's like, till we kind of like have decent numbers, and like till we really do an analysis, we will look more into it. But right now, it's difficult to give you something on top of my head. But that is the expectation. Maybe like this, like those things will come up, I guess, because like what we know about the disease is the tip of iceberg. There is so much more, and with the newborn screen, it has changed the whole paradigm.
And maybe I'll just mention here quickly too. So this is coming out in several phases. I think initially we're just trying to get this off the ground, and eventually did that. And then, about this time last year, we decided that we were going to modify it because we wanted to be able to roll data back out to the sites that are actually doing the screening. And so we had to go through a process of figuring out how to do that and get those things, changed and whatnot. And so that's now up and running, but we really haven't, gone to the mat and trying to get people signed up much yet, because we're trying to get all these things done. And the other piece that's ongoing now, as I kind of alluded to, is APHL is going to help us make these modifications. And so we're actually talking to some of the centers now that are doing newborn screening, trying to figure out what data they really want back from the registry, so we can design reports and whatnot to do that. And we may end up having to modify the protocol a bit again to incorporate what they want. It's gone through a process of evolution, clearly, and I think it probably will a bit more here. And then we're really going to try to do what we can to make sure everybody knows about it, and try to get as many people signed up as we can.
And I think one of the things I would definitely mention here is that a lot of it is very helpful when families put in the comments or they give their feedback. That has helped us modify this registry and understand the issues or how we can improve it way better actually. And like a lot of the modifications that we have done over the years are based on the feedback that we received. And as Dr. Archer mentioned, this is the process of evolution. We do feel we are making it better and better. We are taking like all these big steps, but the feedback is so much important. And if there is anything that we can do to make it better, just please let us know.
Thank you, Dr. Gupta. I can even say personally, as a parent who's filled it out, I can't even remember what it was, but I did have a concern about one of the questions, and he did reach out to me personally to discuss it. So I think it's important that we participate, and eventually this will all have a lot of meaning, for all these questions that are going unanswered. So thank you so much for that.
I had one last question. What about the ability to share this information with other providers and researchers that are doing work in ALD? I know that's the million-dollar question. So.
Yeah, no, I think that's certainly the intent. So, and we haven't really moved to the point where we're starting to do much data analysis, as Ashisha kind of alluded to, but especially as we get a few years into this and have more patients and have more long-term follow-up on patients, then I think it's hopefully going to be really helpful in addressing none of these questions. So, and we'll have a biorepository, so we're going to have samples from these patients, and we're going to have MRIs and other data. And we need to put in place some mechanism so that if people want to apply to get some of the samples or to see this MRIs or something, that there's a process to do that. But certainly the idea is to be collaborative in this.
Great, thank you.